Hello and welcome back to NeoMed AI Research Review, the podcast that turns fresh neonatal research into practical bedside know-how. Today we're asking the simple but urgent question, can we give surfactant through a laryngeal mask airway instead of intubating a preterm baby? Before we jump in, a quick source check for the evidence hawks out there. Today's numbers come from a 2023 Journal of Paediatrics randomized trial by Gallup and colleagues comparing surfactant delivery through a laryngeal mask airway, LMA, with the traditional brief-intubation, surfactant, extubation, INSURE technique.
This study has sparked a lot of corridor chats in NICUs.
Here's how we'll tackle things. First, we'll set the scene with a real-world case, then we'll unpack the trial's design, walk through the results, and finish with pearls, pitfalls, and a quick-fire case twist. Ready?
Let's dive in.
Picture this. You're on nights. A 30-week, 1,200-gram infant is 2 hours old, on CPAP, 6 centimeters water H2O, FiO2 creeping up to 0.45, saturations are wobbling. You decide it's time for surfactant. Now, the question, tube, catheter, or LMA? That's what this trial tries to answer. First off, why was an LMA even considered? LISA and MIST are already fashionable.
True, but LISA needs a thin catheter and a steady hand. Smaller units may only have LMAs to hand, and staff may be more comfortable with that than with tracheal intubation or deep laryngoscopy. Using an LMA could mean no muscle relaxant, quicker procedure, and less airway trauma, if it works as well.
Walk us through the study, but conversationally. No eyes glazing over, please.
Fair. 93 preterm infants, gestational age 27 to 36 plus 6 weeks, weight above 800 grams, were randomized. Initially, it was a straight 1-to-1 split, but halfway through, clinicians favored the LMA, so they switched to a 2-to-1 ratio in its favor.
Bit unorthodox, but carry on.
The LMA group received atropine only, size 1 LMA in, 3 mL per kilogram of calfactant in 2 aliquots, then straight back on CPAP. The INSURE group had atropine plus remifentanil, direct laryngoscopy, endotracheal tube, same surfactant dose, and extubator within 15 minutes if stable.
The headline number everyone quotes.
Early surfactant failure, defined as needing mechanical ventilation within an hour, a second dose, or FiO2 stuck above 0.6, occurred in 20% of LMA babies versus 29% of INSURE babies. Statistically, that's a non-significant difference. P equals 0.31. However, zoom in on first hour failures, and it's 2% versus 12.5%, which is significant. P approximately 0.04.
So fewer immediate crashes after LMA. Interesting. What about safety signals? Air leaks, bradycardia, reflux?
Surfactant reflux was 0 in the LMA arm versus 10% in INSURE. No uptick in pneumothorax, IVH, or mortality. Plus, the LMA group avoided opioid sedation, which many neonates don't tolerate well.
Okay, strengths first. Concealed allocation, pragmatic bedside protocol, and a clearly defined primary endpoint. Also, active extubation within 15 minutes in the INSURE arm, so the comparator was genuinely best practice, rather than prolonged ventilation. Now, the inevitable caveats.
The trial was underpowered. They didn't hit their planned sample. The non-inferiority margin was 20%, which is generous. Smaller harms could slip under the radar. They also changed allocation and tweaked outcome timing mid-study. Purists will raise an eyebrow. And remember, LMAs start at size 1, so infants under about a kilogram are tricky. The device won't fit the tiniest ELGANs.
Right, back to our 30-weeker. You've delivered surfactant via LMA. 10 minutes later, FiO2 is down to 0.28, and the baby's comfy on CPAP. Lovely. But imagine the same infant was 26 weeks and only 750 grams. Your unit's LMAs don't fit. What now?
That's your consultant-level dilemma. In that situation, you'd likely reach for LISA or MIST or a gentle INSURE approach, so keeping multiple techniques in your arsenal is vital. The trial's message isn't scrap intubation, it's add another tool when the anatomy allows.
Let's wrap. 3 take-homes. 1. LMA surfactant is non-inferior to INSURE for preterms greater than 800 grams with fewer very early failures. 2. Skip the opioid. Atropine alone sufficed and may reduce apnea. 3. One size doesn't fit all. ELGANs still need alternative strategies. For everyone listening, here's the thought provoker. If LMAs became first line tomorrow, how would your unit retrain and which infants would still need a tube? Thanks for listening. Check the description box for the full paper. Hit subscribe so you never miss a research review.
Just a reminder, this AI-generated information is for educational purposes only and is intended for trained neonatal clinicians. It does not replace independent clinical judgment. Always refer to the current national and local guidelines.